Fever can significantly affect outcomes in patients with acute vascular brain injury, such as stroke. But can actively preventing fever really make a difference? In this video, we'll explore the findings of the INTREPID randomized clinical trial, which set out to answer that very question. Join us as we dive into the study's objective to determine whether fever prevention can lead to better functional outcomes for patients suffering from these critical brain injuries. The INTREPID trial was designed as an open-label randomized clinical trial with blinded outcome assessment. It enrolled 686 critically ill stroke patients across 43 intensive care units in 7 countries between March 2017 and April 2021, with the final follow-up date being May 12, 2022. Patients were randomized into 2 groups. One group of 339 patients received active fever prevention, where their body temperature was targeted at 37.0 degrees Celsius for 14 days using an automated surface temperature management device. Meanwhile, the standard care group, consisting of 338 patients, received fever treatment only when their body temperature reached 38 degrees Celsius or higher, based on a standardized tiered approach. The primary outcome measured in the trial was the daily mean fever burden, calculated as the area under the temperature curve above 37.9 degrees Celsius, divided by the total number of hours in the acute phase, and then multiplied by 24 hours, degree C hour. In terms of secondary outcomes, the focus was on 3-month functional recovery, assessed using a shift analysis of the 6-category modified Rankin scale, which ranges from 0, that is no symptoms, to 6, that is death. The trial also monitored major adverse events, including death, pneumonia, sepsis, and malignant cerebral edema, to evaluate the overall safety and efficacy of fever prevention strategies in critically ill stroke patients. After a planned interim analysis, the trial was stopped due to futility in achieving the principal secondary endpoint. A total of 677 patients were included in the primary analysis, with 433 completing the 12-month follow-up. The results demonstrated a significantly lower daily mean fever burden in the fever prevention group, 0.37 degrees Celsius hour, compared to the standard care group, 0.73 degrees Celsius hour, with a difference of -0.35 degrees Celsius hour, 95% confidence interval between -0.51 to -0.20, p less than 0.001. This reduction in fever burden was consistent across stroke subtypes, with significant differences seen in intracerebral hemorrhage and subarachnoid hemorrhage patients, p less than 0.001. However, there was no significant difference in 3-month functional recovery, as measured by the modified Rankin scale, between the 2 groups. Additionally, major adverse events were slightly more common in the fever prevention group, 82.2% vs 75.9%. But the rates of infections, cardiac, and respiratory disorders were similar between the groups. In conclusion, while the use of an automated surface temperature management device effectively reduced fever burden in patients with acute vascular brain injury, it did not translate into improved functional outcomes. These findings suggest that although fever prevention can control body temperature, it may not impact long-term recovery in critically ill stroke patients. This highlights the need for further research to explore alternative strategies for improving functional outcomes in this patient population.